So my talk is on perfusion stress echo. So the question really is, why do we need to do perfusion stress echo? So if you look at the sequence of myocardial events that occur during demand ischemia, you will see that the earliest abnormality that occurs is a perfusion defect. And then when the demand exceeds the myocardial oxygen supply, myocardial dysfunction occurs. Now, myocardial dysfunction can be seen by echocardiography, by assessing wall motion abnormality, by assessing strain, etc. Now, these are all myocardial function. But if you look at perfusion, you'll be able to pick up the disease earlier, and also you can pick up milder disease. Therefore, potentially, looking at perfusion makes stress echo that more sensitive. So that's the reason for perfusion. Now, so how do we do perfusion? Now, what you see here is a video image of a capillary, and what you see there is a large particle and small particle. The larger particle are the microbubbles, and the smaller particles are red blood cell. And you can see that the contrast, the microbubbles track exactly like the red blood cell with the same rheology, and therefore it is a perfect myocardial blood flow tracer. And I think this is a perfect myocardial blood flow tracer compared to any other tracer that we see in cardiology, including SPECT, which is actually doesn't stay intravascular, and gadolinium also is the same problem. It's not intravascular, it leaks out. So this is a perfect technique to assess myocardial blood flow. Now, so when you inject contrast, and when a steady state is reached, and if you put a region of interest in the myocardium, what you get is a relative capillary blood volume. So what you're actually looking at are capillaries with the microbubbles, because 90% of the microcirculation that you see here are capillaries. And so you see the capillary blood volume, and then you can clear the microbubbles from the myocardium and from the capillaries by increasing the mechanical index of the machine. So as Rick has described, so here we are using very low power imaging, 0.1, so that we can image the microbubbles continuously. And then when you increase the mechanical index to 1, then you destroy the microbubbles, as you can see in this frame. So you destroy the microbubbles, and you allow the microbubbles to come back into the capillaries. And when you do that, and when you assess that, you get myocardial blood velocity. So you get myocardial blood volume, you get myocardial blood velocity, and I think this is a unique technique to look at the components of myocardial perfusion. So you're looking at blood volume and blood velocity, and this is a version of that. So flash replenishing here, you can put a region of interest there, and what you see here is, so there's a time intensity curve. So that's the velocity, and that is the capillary blood volume. And when you multiply these two, you get myocardial blood flow at rest. And then during stress, you can do the same, and you get myocardial blood flow during stress. And the ratio of the myocardial blood flow during stress divided by the rest flow gives you myocardial blood flow reserve, or some people call it coronary flow reserve, but this is really looking at myocardial blood flow. So it is a perfect way of looking at myocardial blood flow reserve. So, but is it accurate? Now, this is a comparison with PET in humans, right? And you can see there are many dots here, some at rest, some at hyperemia, meaning after stress. And you can look at the line. It's almost perfectly matching what you can see with PET. So without radiation, at the bedside, you can get a perfectly accurate way of assessing myocardial blood flow. Now, does it really work in patients? So these are various examples that are shown in patients. For example, this is in stable angina patients. And what you see here very uniquely is, so this is looking at luminal stenosis here, and that is looking at myocardial blood flow reserve. And you can see as the stenosis exceeds 50%, the blood flow reserve begins to go down from about 2.5 to below 2, and the greater the stenosis, the lesser the myocardial blood flow reserve is. And this is looking at patients after acute myocardial infarction, post-thrombolysis, looking at residual coronary stenosis, again showing the same phenomena. Greater the stenosis, lesser the myocardial blood flow reserve. And these are patients in acute heart failure with, where we are attempting to see whether the patient's got coronary disease or not. Again, you can quantify it and actually say what the severity of stenosis in this patient. Now, these are groups in patients with left bundle branch block, which is one of the problems that we have when we do stress echo. And again, in that same group of patients, you can see how it tracks very nicely the quantification of assessing myocardial blood flow. Now, what you can also look at is, now these are patients without coronary artery disease, but with impaired microcirculatory conductance, meaning these are patients with so-called microvascular angina. And here you can also see that the myocardial blood flow reserve is reduced. But the unique thing about this is that here, what is reduced is not the capillary volume, but just the velocity. So if you look at it, this is in control. You can see after hyperemia, the velocity goes up, exponentially, while the capillary blood volume doesn't change very much. Now here, what you see here is that the velocity doesn't go up that much. So it is the impairment of the blood velocity that occurs in this group of patients. And in contrast, this is another problem with microvasculature, which is called arteriolar dysregulation, where actually the microvessels are very reactive. So with a stimulus like acetylcholine, they go into spasm. So you can see this is one of the studies that I did actually in Stuttgart with Professor Sektem, who specializes in this technique. So the acetylcholine is given, coronary arteries are fine, there's no change in the coronary arteries, but the patient began to complain of chest pain. And this is at rest. So baseline perfusion, you can see it's nicely perfused, the apex, the septum, etc. But you can see where acetylcholine was given, the capillary blood volume has gone down markedly, and there's wall motion abnormality also at the top. So you can look at various degrees of abnormality or various types of abnormalities, looking at whether the velocity has gone down or the capillary blood volume has gone down in patients without coronary artery disease, and it gives you an estimate of what you may give in terms of therapy. So now, in echocardiography, of course, we are busy. We want to do things very, very quickly, right? Because we don't have time. So now in coronary artery disease, what happens is that the greater the stenosis, there's greater the reduction both of the velocity and the capillary blood volume. But there is a difference in the way it appears compared to what I showed you just before. So both get reduced. So what happens is, if the myocardium is completely normal, meaning there's no coronary stenosis, then the myocardium fills within 2 seconds of flash, meaning you destroy the microbubbles come back into the capillaries within 2 seconds. But beyond that, the greater the stenosis, the later it will come. So let's look at 2 examples. So on the left is an example where we've given a vasodilator, and it's 60 beats per minute. And you can see immediately after the flash, the epicardium to endocardium fills simultaneously. This filled in 1 second. So you're allowed 2 seconds, and it's 60 beats per minute. If the heart rate is 120 beats, then it should fill within 4 beats, right? So you convert the seconds into beats depending upon the heart rate. Now, this is another patient. Again, this patient also received vasodilator. Again, it's about 60 beats per minute. Now, if you watch here, you will see the flash coming up, and immediately after flash, you see, compare this and compare that. You see a subendocardial defect in the septum and a marked defect in the lateral one, and look at the intensity of the epicardial vessels filling. This is a classical coronary artery disease pattern, which is different from microcirculatory disease because there it will be more patchy, but this is more subendocardial. And you can just by this frame can say, this patient has got coronary disease, and this patient's got multivessel coronary disease, and you can also predict that the LAD stenosis is less severe than the non-LAD stenosis, meaning anterolateral is circumflex region. So look at how it fills. So it fills from epicardium to endocardium, right? And this is the angiography of the same patient. You can see there's a 70% stenosis of the LAD and the blocked circumflex, and that's why the lateral wall was so delayed in filling compared to the LAD. Now, how does it differ from perfusion with SPECT? Now, the problem with SPECT perfusion is, actually it's not perfusion, it's myocardial blood volume. You can assess only myocardial blood volume with SPECT. And it's called perfusion technique, but it's not a perfusion technique. So does it really matter? So if you look at this slide here, you'll see that if you look at no stenosis, mild stenosis, severe stenosis, and this is capillary volume and this is velocity, if a technique just looks at capillary blood volume, you will not be able to distinguish no stenosis versus mild stenosis. You'll see there's not much difference. But of course, if the stenosis is severe, it goes down quite a lot. But if you're using a technique where you're looking at velocity, you will see that the difference is more stark here, right? It comes down to half of what it should be normally. So a technique that looks at velocity has to be more sensitive than a technique that just looks at myocardial blood volume. So this we tested in a large number of patients. It's a European multi-center study involving 34 centers, comparing myocardial contrast echo with SPECT, and all the images are read blindly but in another center. And what we found is that myocardial contrast echocardiography was significantly more sensitive than SPECT. However, myocardial contrast echocardiography was less specific than SPECT. Now remember I told you that myocardial contrast echo picks up microcirculatory disorder very clearly, even with normal coronary arteries. So we said, okay, if that is so, then if you follow these patients up, patients who had undergone myocardial contrast echo will show greater number of events than SPECT would. So these are follow-up of the patients, not of all the patients, but in a group of patients, and you will see that if you look at all the variables, clinical variables, left ventricular systolic dysfunction, and you add SPECT on top, you get some improvement, but if you add myocardial contrast echocardiography on top, you get the greatest improvement in terms of outcome. So it's a technique which is both gives you diagnosis and prognosis of coronary artery disease. Now, I'll just show you an example of a patient who had undergone SPECT. This is a patient who had got heart failure, ejection fraction low. The question is whether the patient is a known three-vessel disease, whether this patient got ischemia. So now this is a SPECT study. You can clearly see that there is lots of viability, lots of uptake, but there is no reversibility at all. So in my lab, we were a bit surprised to see that because the patient's got a three-vessel disease. If the patient's got viability, there has to be some ischemia. But it's not shown. So they asked me to do perfusion scan with echo. So this is the perfusion study of the patient. So you can see here, so now this still image, right? And you can see there's a lot of contrast uptake. So there's a lot of viability. Now, this is flash replenishment again, the same sequence, flash, and you see it coming, and you can see now immediately after the flash, look at the amount of defect there. Large areas of defect, not only of the septum, but the large area of anterolateral wall, and then you see it gradually begins to fill up, slowly. And similarly, if you look at this, so this is during dobutamine, right? And look at the heart rate, it's about 140 or something. So flash, you'll see the inferior lateral fills up very quickly, but look at the septum. It's filling up very slowly. So we demonstrated ischemia, and this, on the basis of this, the patient underwent revascularization. So now, how do you do perfusion stress echo? You give contrast, you give enough contrast so that the LV opacification is uniform, and you begin to see perfusion within the myocardium. At this point, you are in your perfect image acquisition. And once you've done that, then this is the result, rest and stress. Now you can see the myocardium you can see the capillary volume there. And this is enough. And you can see wall motion is completely normal. And then as soon as you acquire those images, you come out of it, pause your protocol, and go straight for flash replenishment. Here you are, flash, and then it replenishes very quickly. And so you set the MI, flash MI frame to about 0.8 to 0.9, acquire about 10 cycles post-flash, obtain complete clearance of the microbubbles. And how do you do that? You optimize by increasing the flash frames or increasing the flash mechanical index or even reducing the gain. If the background gain is too high, you can get false speckles there. And basal, if you see basal defect, just try and move your transducer axially so that the lateral wall comes in more in the center. So how does perfusion provide incremental value of a wall motion? So I told you that perfusion abnormalities occur earlier. But more importantly, what we face in day-to-day clinical practice is we see subtle wall motion abnormality, we are not sure. And what we do is if the perfusion is also abnormal, we call it coronary artery disease. Then the next group is, again, subtle wall motion abnormality, but completely normal perfusion, no coronary artery disease. And then finally, we have a condition where there's bound or inducible wall motion abnormality during stress, but completely normal perfusion. That is not ischemia. You can't have ischemia with normal perfusion. That is more likely cardiomyocytic disease or like Takotsubo or even myocarditis. I'll show you some examples of those. So this is a patient who was referred to me from my esteemed colleague, Carlo Di Mario, for a patient flew in from Kuwait and said, okay, this patient got atypical chest pain. Can you do a quick stress echo? The beauty of stress echo is that you can give the result straight away. As soon as you do it, you can ring your colleague and say, this is what it is. So we did a stress echo. So these are all sequences. And really, we don't see any wall motion abnormality. Now, right here, we were suspecting something, but we are not sure. It's still thickening. Maybe a little late, tyrosinesis maybe. But tyrosinesis can be very nonspecific. It is sensitive, but nonspecific. And as we do perfusion imaging all the time in most of our patients with stress echo, so we did perfusion. And if you look at it there, so that's the real-time perfusion. So flash, and look at how the septum fills up, and look at the defect at the apex. But this is the triggered imaging. We also do that because that you see the perfusion defect much more clearly and see how it begins to fill up. And here in the two-chamber view, you see the same. So we were absolutely convinced there's a subendocardial defect filling from epicardium to endocardium. This is coronary artery disease, and the patient has got coronary disease. So we rang Carlo and said, okay, this patient needs an angiogram, and the patient then flew into the cath lab instead of going back to Kuwait. And this is the angiogram blocked LED. Now you might say, well, there's perfusion defect only at the apex, 5 segments, and it's a completely blocked LED, but look at the collaterals here. So this collateral is maintaining some of the perfusion, but the point is the patient has significant coronary artery disease. Now this is another example of another patient, rest stress. Now I'm not sure what's happening here. Is there wall motion abnormality? It looks like it, but look at the perfusion image here. The same patient, perfusion, flash. So flash comes in, and look at how it fills up very quickly, completely. So we called it normal. Now, this is another patient, 53 years old male, presented with acute coronary syndrome, and on angiography, there is myocardial bridging. So the question is whether that myocardial bridging has caused an infarct, meaning there could be plaque there because myocardial bridging can cause plaque, and that has ruptured, and now is there residual stenosis. So I was asked to do the stress echo. So I did the stress echo. At rest, stress, you can see how the apex has dilated. So clearly there is ischemia. Now remember, clearly there is wall motion abnormality. Clearly the apex has dilated. But is there ischemia? Now based on this patient would receive a stent because it's causing ischemia, that bridging. But we did perfusion here. And if you look at the perfusion, so this is a flash coming up now, and you can look at it. It fills completely normal. So it cannot be ischemia. The wall motion abnormality is not ischemic, it's myocytic. This patient has Takotsubo. So this is our experience of using stress echo with myocardial contrast echo within 45 minutes. Everything is done, and you can see that myocardial perfusion imaging actually helped us in 88% of the time not by showing early abnormality, but it helped us to decide with greater confidence the wall motion, whether the wall motion is truly abnormal or is it not abnormal. So that's where actually it really scores. But in addition, it does pick up coronary disease better than just wall motion on its own. And this is the data from several investigators. This is our study showing that with the wall motion and perfusion is normal, the outcome is excellent. If there is perfusion defect in absence of wall motion or subtle wall motion abnormality, the prognosis is poor. And it becomes poorer if both are abnormal. Now, I'll show you another example in our lab. So this is a 75-year-old male, and I'm going on to another topic now. Three-vessel disease, LVF 28%, and severe chronic renal failure. The surgeon said, I want to know whether the patient has got ischemia in the LAD territory and whether there's viability. Otherwise, I'm not going to operate on this patient. And this is a surgical case. You can't do a PCI because there's other issues with this. And it's a high-risk patient. So we did a stress echo, dobutamine. Now, rest, intermediate, peak. Now, I couldn't make any head or tail of what's going on in the septum. The septum hasn't moved or shifted from baseline to peak. And I couldn't say whether there's viability or no viability. Now, as I've said, we do contrast in all of these patients. So this is the rest contrast of the patient. So this is rest study. Now, if you look at the rest study, it is quite clear that despite the thinness of the septum, there is a lot of capillaries here. See? It all fills up very nicely. So there's a lot of viability, and we've shown before that if the capillaries are there, then there is no infarction. If there are no capillaries, then there could be transmural infarction, and we've also shown that it translates into bad outcome if there's no, if there's not much myocardial viability. Now, this patient then underwent stress echo, as you saw, and we did a peak imaging of, if you look at it now, so now this peak stress, and now look at the perfusion defect there. So at rest, there was capillary perfusion. During stress, it's down. So that's ischemia. And it's not blooming because it's different from rest and stress. Now, we know from data that dobutamine stress echo is excellent for looking at myocardial viability. However, its sensitivity tends to be lower compared to techniques that looks into metabolism or technetium uptake, etc. So if a technique that looks into contractile reserve tends to be slightly less sensitive. Why? Because this is our study again where we looked at hibernating myocardium versus necrotic myocardium versus normal baseline function. And if you look at the coronary flow reserve in hibernating myocardium, it is very, very low. So even a little bit of dobutamine can cause ischemia, and you will not see contractile function. Whereas if you look at a capillary volume, you will see it is low, but not that low compared to necrotic myocardium. And that's why myocardial contrast echo can be more sensitive than dobutamine stress echo to look at myocardial viability, and this is a meta-analysis that we did. And you can see here that with myocardial contrast echocardiography, the sensitivity can be high as 87% compared to dobutamine, but the specificity is low. But if you combine the two, so the way we do it is, if we find that the wall is non-responsive with dobutamine and the wall is thick, it's not like scarred, thinned out, then we look at perfusion to be sure that we are not missing myocardial viability. So now, these are the guidelines, recent guidelines from Europe, from America, and even the ESC guidelines recommend stress echo perfusion as a valid method in stress echocardiography. And even the most recent 2019 guideline just published about a month ago clearly says that if you want to look at perfusion changes, you can do so with SPECT, with positron emission tomography, myocardial contrast echocardiography, or contrast CMR. So it is now classified at the same level as the other techniques that we use here. Thank you.